Hi everybody, this is Laura Kaiser presenting on lower extremity arterial disease. This is the third in a set of 3 series talking about lower extremity wounds. This is review. We talked about the lower extremity wounds quick reference guide put out by the WOCN Society. This is used to differentiate the different wounds between venous, arterial, and neuropathic. For review, we talked about lower extremity neuropathic disease, which is LEND. These patients usually have diabetes, peripheral neuropathy, or Hansen's disease, known as leprosy. This patient has the insensate foot, which is the problem, and we talked about insensate foot being a blessing and a curse. The blessing being that if they have a wound, they don't really feel the pain that a normal person would feel. And the curse is that the insensate foot is the reason they get the wound in the first place. Best practice to treat neuropathic ulcers, also known as diabetic foot ulcers, is to offload and debride, and we can't say that enough. We need to offload the pressure that caused the wound, and we need to debride the necrotic tissue and continue to offload till the wound heals. And we continue the wound care following the general wound care principles that we talked about. The lower extremity venous disease, we discussed this on our last presentation, known as LEVD. These lower extremity venous disease patients have associated diagnoses like congestive heart failure, lymphedema. They could have had orthopedic procedures or advanced age. They end up with the venous stasis ulcer or the venous dermatitis, and the treatment for venous insufficiency ulcers is compression therapy. And today we'll talk more about complications related to compression therapy and the need for thorough assessment. So this brings us to our topic that we're discussing today, is the lower extremity arterial disease, also known as LEAD. Patients have associated diagnoses such as cardiovascular disease, vascular procedures or surgeries, sickle cell anemia, obesity, or smoking. The classic symptom for patients with lower extremity arterial disease is intermittent claudication. It's the tight aching or squeezing pain in the calf, foot, or thigh, or even the buttocks, and it occurs during exercise. When a patient walks up a steep hill or a flight of stairs, it usually occurs after the same amount of exercise. It intensifies until the exercise becomes impossible, and when the patient rests, then it is relieved. Pain in the calf, muscle, feet, and as the disease progresses in the toes while at rest. Lower extremity arterial ulcers, very important to get ABIs, do vascular studies, and this sometimes leads to critical limb ischemia. Smoking is one of the worst things for the arterial disease because of the blood vessels that's restricted. We really should encourage our patients to stop smoking. Factors that contribute to lower extremity arterial disease include plaque, which is on the inside of the arteries, and this is the most common problem. High cholesterol, high blood pressure, and smoking are different factors that continue to lead to the arterial disease. How is lower extremity arterial disease diagnosed? The physical exam tells us a lot. We need to see if we can palpate the pulses. We check for temperature changes in the extremities and see if the temperature is cold. You can also note the color changes in the lower extremities. We can do the ABI, which is a simple diagnostic test that can be done in the home. And then we send for vascular studies if all these point to arterial disease in the patient. The ABI, also known as a ankle brachial index, is the ratio of the systolic blood pressure measured at the ankle to that measured at the brachial artery. This was described by Windsor in 1950, and it's a relatively simple diagnostic test done with blood pressure cuffs. And we look at the value. The value can be greater than 1.4. These patients are also referred to a vascular specialist because really they should not be above 1. If it's above 1.4, it should not be above 1.4. If it's above, then it could be related to the calcification of the arteries, and the arteries are not compressible, and this is common in diabetic patients. If the ABI value is 0.9 to 1.4, there's not really much recommendation unless there's other factors that contribute to it. 1.0 to 1.4 is considered normal, and 0.9 to 1.0 is acceptable. If it's 0.8 to 0.9, this patient may have some arterial disease, and we treat the risk factors that are causing the problem. If it's 0.5 to 0.8, the patient does have moderate arterial disease, and these are patients you want to refer to the vascular specialist. Less than 0.5, they have severe arterial disease, and you really want to refer these patients, and they may have what we call critical limb ischemia, where there needs to be test and treatment done right away. How is lower extremity arterial disease treated? Well, the treatment includes ways to relieve the symptoms and lower the risk of a heart attack and stroke. A healthy lifestyle changes and medications sometimes relieve the symptoms and lower their risk of heart attack and stroke. But in some cases, they may need surgery or a procedure called angioplasty. And that's where the vascular surgeons go in and take care of the blockage. Lifestyle changes, some things you can change, some things you can't. But if the patient smokes, tell them they must quit to improve their flow. They can change their diet, eat healthy foods. They could follow an exercise program. They need to manage their cholesterol and blood pressure if those two things are high. If the patient has diabetes, they need to keep their blood sugar in a target range. And also, if they need to lose weight, they need to do that to maintain a healthy weight and just have a healthy lifestyle. The wound care plan, we continue to follow the nursing process, the assessment, diagnosis, planning, implementation, and evaluation. Your assessment for lower extremities must include the color of the skin. Is it different? Is it pale, or is it red? Is it abnormal? Look at the hair pattern. If the patient has no hair on the bottom of their legs, ask them if they ever had hair. If they never had hair, then you really can't tell the difference. But if the patients had hair and then the hair stopped growing and they noticed that, then usually that has something to do with the arterial disease. Notice the temperature. Usually a patient with arterial disease has a cool, cold feeling. Their skin is tight and shiny. The pulses are not palpable, and this is where it's important to really try to palpate the pulses. You want to palpate the posterior tibialis and the pedal pulses. If you can't, then you can try to use a Doppler and report these findings to the physician. Check their capillary refill. Usually these patients don't have a very good capillary refill. You pinch the toe and it stays white for a while. Check for claudication. That's when the patients have vascular problems, and it's indicative of the lower extremity arterial disease. Ask the patient if when they walk, do they have to stop because of pain in the leg, in the calf, sometimes in the foot, in the buttocks or the hip, and also if they have rest pain. Ask them if they can elevate their feet in the bed, or does that cause pain? Sometimes these patients will tell you, I have to sit on the side of the bed for my legs not to hurt. because any elevation causes pain because of the circulation. Here's a little cartoon that I thought pretty much describes peripheral arterial disease. The toe says, hey, what's going on? We can't feel anything. We're hungry. What happened to the blood with the oxygen and nutrients? Then up the ankle, the little guy says, these pipes are all clogged with plaque, no blood flow. Atherosclerosis has been here. The other toes say yes. And how do we get rid of this waste? The acid building is, the lactic acid is building up in our tissues. Peripheral artery disease develops in patients with diabetes and atherosclerosis, and it can lead to tissue death. And the little dog says, watch out for gangrene. It doesn't need oxygen to live. So just the decreased circulation, decreased blood and nutrients and oxygen to the peripheral tissues can cause tissue death, and that's when we end up with a serious problem. An abnormal ABI test result may require more testing to determine the location and the severity of the peripheral artery disease, which is also lower extremity arterial disease, that might be present. The next two slides are kind of an algorithm on what we should do based on our assessment. The history and physical examination suggests peripheral artery disease without rest pain, a non-healing wound, or gangrene. We want to suspect critical limb ischemia, which we'll show you on the next slide. An ABI is done with or without segmental limb pressures and waveforms. This is a test, an ABI, that is done in a physician's clinic or at the hospital. The ABI that we do in the home is a lot more simple than this, but if you look at the non-compressible arteries with the ABI and it's greater than 1.40, then they go down to do a toe brachial index, and that brings us down to, if it's greater than 0.70, then we search for an alternative diagnosis and find out more what's going on. If it's abnormal and it's less than or equal to 0.7, then we find out, is it, do they have claudication that interferes with their lifestyle? And is revascularization considered? If yes, then the patients can go for an anatomic assessment where they do the duplex ultrasound and they do all the rest of the testing that is more than what we can do in the home. They can do the anatomic assessment with invasive or non-invasive test. If the ABI is normal or borderline normal, then we find out, do the patients have the related leg symptoms? If it's yes, then we encourage them to exercise. If it's no, then we search for an alternative diagnosis. If the abnormal ABI is less than or equal to 0.90, then we go down the algorithm and we refer them to vascular. They can do an exercise ABI, which will tell more than the resting ABI. And in the red box it says, do not perform invasive or non-invasive anatomic assessments for asymptomatic patients. Okay, this tells us the diagnostic testing we want to do for suspected critical limb ischemia. These patients are the ones that come in and they're less than or equal to 0.5. If they have a history and a physical examination suggestive of peripheral artery disease with rest pain, non-healing wound, or gangrene, then we want to go and do more of the testing. In the testing, if you see in the yellow on the left, the perfusion assessments, we can do the toe brachial index, The TCPO2 is TCOMS. This is a test that they do in wound clinics to test for the level of skin perfusion, and sometimes this is done if they're going to do an amputation. Then they find out exactly where's the level of perfusion, and they do the amputation right at that level or slightly above, and this predicts wound healing. And these two algorithms come from this website. Okay, if you refer to the ABI chart, it helps you to understand how to perform the ABI. And we'll talk about that as we end the presentation. If you have any questions, feel free to contact me through email or call me, and I'll get your questions answered. Thank you for your attention to this presentation.